So other treatments that are used in our armamentarium that I think is something that you could try is a combination that my colleague Mark Davis at Mayo Clinic published with a neurologist way back 3 years ago, and we have adapted it but went for higher concentration using ketamine, which is an NMDA antagonist, lidocaine 5% and amitriptyline, and a base which enables it to penetrate to the skin. And they're targeting ion channels, and I find this is the most robust itch effect in these patients. We've collected data of more than 100 patients we gave them, so hopefully this year we'll have a publication on how to use it, what are the side effects. It's a rather safe drug. People are concerned about, you don't want to give ketamine systemically because it's a drug, a party drug, it's a serious one. Could cause a lot of problems, but in terms of permeation and systemically with these concentrations, even in large application in the body, very limited effect at this stage. So we're not concerned about using it in patients. Wouldn't someone ask me that he wants to put it orally? No, that I wouldn't recommend. Another drug that is not in the market is targeting of NGF, nerve growth factor receptor. The trick A is the receptor for nerve growth factor. This drug we've tested and published in psoriatic itch, but it's not yet in the market. I think that the new drug that you'll see in the market is crisaborole, the topical PDE4 inhibitor. It clearly works for itch and atopic eczema, and I won't be surprised that it could work for other types of inflammatory itch. TRPV1 antagonist, we've tried that. We failed one, but I'm sure that there could be other drugs that could work. And botulinum toxin type A, this is another exciting area that hopefully I could elaborate later on this year. And in terms of understanding other treatments, let's go the upper level is to try to target the spinal cord and the central nervous system. And because, again, the pathway of itch goes up to the brain. So the question is how to reduce that hypersensitization of the nervous system in order that the nervous system will respond normally to these itch inductions. So we have now neuromodulating agents, drugs such as gabapentin and pregabalin that you're well familiar with. And there are some antidepressant drugs as well as kappa opioids and such as butorphanol. So the drugs I use for what we call SNRI, selective norepinephrine reuptake inhibitor, is mirtazapine. And I use sometimes a combination of both mirtazapine, gabapentin, and pregabalin. All of this dampens that hypersensitivity that I showed to you as a essential component of that chronic itch. As I mentioned, opioids have overexpression in some types of chronic itch. And in Japan, there has been, since 2009, a drug called naltrexone, which is a kappa opioid agonist that works for uremic itch. Unfortunately, the drug trials here in the US did fail. But the question is there anything that is similar? And way back with my colleague, hepatologist Nora Bergassa, who's the world expert in hepatic itch, we found that there's actually a product in the US market called Butorphanol. It's an inhaler. It's a pre-anesthetic, doesn't work so well as a pre-anesthetic. It's given for migraine headaches. And we started giving it to patients with intractable itch, and it does actually work. So I don't know if any one of you tried that. It's not my first line of treatments. The DA monitored my practice because I'm the #1 dermatologist giving that drug, and it's a controlled substance. It's not addictive, by the way, but it does cause drowsiness, really weird dreams, I have to tell you. I mean, we have to publish that sometime, causing some dreams that they see the devil, but it's interesting because they continue using it, so it's not so bad, that devil, but in a way, it's not addictive, but it's considered an addictive drug, so I have to mention that. And we've used it as a treatment for intractable chronic itch patients, but nothing else helped them. And we actually developed a transdermal delivery of butorphanol that makes more sense for dermatologists, but at the time that I was practicing at Wake Forest, the patent lawyer said there's no market for it, and we didn't register it, which was a big mistake, because a year later, another company did actually develop a kappa opioid, and it may end up in the market. But so this is for you, Adam, that pursue your interest and don't give up on some, because some of the most interesting ideas, you have to be persistent and not give up to these lawyers. Anyway, butorphanol is an interesting molecule, and I wanted to look at its effect on brain mechanisms of itch, because it wasn't clear where it works. And this is the first drug trial that uses brain imaging with functional MRI, looking at its effect versus placebo. And in fact, we've shown that for histamine itch, not so much for the non-histaminergic pathway, we don't know why, but it does, we know at least how it works on the brain level. So it activated, again, areas in the brain that are involved in reward, and the inhibition of itch, which was dramatic. So any itch induction with histamine, butorphanol totally inhibits that itch, and it works through a mechanism in the brain of activation, again, areas that are involved in the reward system, the nucleus accumbens and septal nuclei. So this is an exciting area, because I think it opens the field for exploring other drugs that work on itch on the central nervous system. Another interesting kind of molecule and a target is the neurokinin-1 receptor. This is a receptor for substance P. The drug that some of you heard of and was published in New England is aprepitant. Aprepitant is a NK1 inhibitor, is given as an antiemetic for cancer. Interestingly, my experience with it is not so great. Rarely it worked for my patients, but Adam is treating one of my patients, says that it works for her now, so I'm very happy. But other derivatives of this drug, other NK1, we've finished a study on serolipitant that showed significant itch reduction, and there's others in the market that will be in phase 2 and phase 3. So I'm quite hopeful that one of these drugs will end up in the market. As I mentioned, the biologic treatments is a very exciting treatment, especially the dupilimumab will be launched the end of this year or next year. So this is exciting for all our atopic eczema patients. But clearly the ones, secukinumab and ixekizumab, have antipruritic effect in psoriasis, and I won't be surprised that they have antipruritic effect on other skin diseases. Just a condition where you see, and always is frustrating, and as I mentioned, these are patients have the most severe itch, is prurigo nodularis patient. One of my hypotheses is that prurigo nodularis is a neuropathic type of itch. Why? If you look histologically, a lot of times there's hypertrophic nerves in H&E. And just the other aspects of it is it's more common. You see quite a large number of African Americans. Prurigo nodularis is very common in atopic dermatitis in African Americans, so do remember that. It's also common in systemic diseases in uremic, not so much hepatic for some reason, and also a lot in stress and obsessive compulsive disorders. So how do I treat prurigo nodularis? I use those regimens of ketamine, lidocaine, and amitriptyline. We've used also topical EMLA with capsaicin. I use high-dose antiepileptics, the gabapentin up to 3,600 milligrams. So you do it, you increase it gradually, and pregabalin up to 400 milligrams. And I use also thalidomide, which I think is the best treatment for it. And as I mentioned, aprepitant, butorphanol. And sometimes there is a component of inflammation that you need to address there, and using cyclosporin. And remember also that intralesional corticosteroids with cryo could help significantly. Remember that not all itches arise in the skin. There is neuropathic types of itch, this is associated with damage along the afferent nerve fibers. One of those that you're well familiar with is brachioradial pruritus, and another example is notalgia paresthetica. BRP is associated with a compression of cervical spinal nerves in C4, C7, and is in most cases bilateral, while notalgia paresthetica is unilateral. Just something that, again, I learned from patients is that always ask patients where the itch started. We've noticed and published that 2 years ago is that BRP may trigger a generalized itch, and this is again related to that hypersensitization phenomena. So we've documented, and I've heard from other colleagues in the US and in Europe that this is more common than we thought. So I have at least 20 cases where it started as BRP and then it spread all over as an itch. So it's an important question when you take history is where the itch started. So if it's in the dermatome distribution of the arms or upper shoulders and then it spreads, think about BRP, because it's a treatable disease in most cases. Remember that neuropathic itch could be scalp pruritus, could be vulvar and scrotal itch that could be, again, associated with damage to spinal pressure on nerve and a nerve impingement. So how do I treat neuropathic itch? Again, the topicals that I mentioned before. Here I would add also something that is good to use for these type is topical aspirin. Aspirin orally doesn't work for itch, but topically it has some effect on reducing itch and also in postherpetic neuralgia. High-dose gabapentin and pregabalin is another treatment that in most cases really helps neuropathic itch. Have to mention also that stress is a significant component of itch, and it intensifies. The more you have stress, the more you have itch. We've looked at the autonomic nervous system. This is a study that we did way back, that the autonomic nervous system, the cholinergic one, is not responding well to the stresses. So yes, we all speak about the sympathetic overactivity, but it's actually the parasympathetic that is not functioning well and is not responsive to the sympathetic overactivity. And that again leads to the use of some of the drugs that I mentioned that can reduce these elements, such as the antiepileptics, some of the H1 blockers, and the antidepressive medications. But do remember that not all patients would respond just to pills, and I think that it's important to understand, very similar to what's going on in pain and chronic pain, is that we have to address other components. So there are also cognitive and emotional aspects, and that helps in terms of treating and managing chronic pruritus patient. And